So the case we are presenting today is a 61-year-old man who presented with nausea, vomiting, decreased appetite, and occasional generalized itching, all fairly non-specific symptoms that we frequently encounter in our patients who have liver disease in general. This person's medical history was notable for diabetes, which was medically controlled. He also happened to have hepatitis C and hepatitis B at the same time, two infections that we often see coexisting in the setting of shared risk factors. He was treated for hepatitis C 6 years ago, we presume, with cure, which is a fairly common outcome of hepatitis C these days. We can't usually cure hepatitis B, but we can very effectively control it with antiviral medication, which I'm assuming he had initiated at the time. And he was diagnosed with hepatocellular carcinoma, an unfortunate but fairly common consequence of longstanding liver disease, in December 2018. His physical exam at the time of presentation revealed scleral icterus, jaundice, spleen was palpable down to 4 cm below the costal margin, which clearly indicates that he had splenomegaly, another telltale sign of portal hypertension and the presence of cirrhosis, which would have set him up for the development of hepatocellular carcinoma. He had a workup done which included an alpha-fetoprotein, which was elevated at 436 nanograms per milliliters, a bilirubin of 1.6, which is above the normal of up to 1.0, an AST of 105, an ALT of 110, an alkaline phosphatase of 390, an INR which was prolonged at 1.9, an albumin which was within the upper limit of normal at 3.8, a BUN of 13, and a creatinine of 1.0, which is normal. His platelet count was 95,000, another indication that he likely had portal hypertension and cirrhosis. And as I mentioned before, he had exposure to both hepatitis B and hepatitis C, although, as I already mentioned, he was treated for the latter. His abdominal ultrasound revealed 3 small hepatic lesions. His chest and abdominal pelvic CT scan confirmed 2 focal nodules in the right and 1 in the left hepatic lobe. These measured 3.6 cm, 4.9 cm, and 5.2 cm. And he had a suspicious lesion in the right lower lung lobe, which we unfortunately sometimes detect on scanning of the abdomen and pelvis because that frequently captures the lower part of the lungs. He had fairly widespread lymphadenopathy, which was additional circumstantial evidence, which we will confirm in a second, that he might indeed have metastatic disease. His biopsy showed findings of hepatocellular carcinoma. We are told that he had grade 3 disease. Grade is one of those things that in hepatocellular carcinoma can be given a fair amount of attention or not. In the setting of metastatic disease, probably not as much. And he had marked fibrosis consistent with the diagnosis of cirrhosis. As with any reasonable workup for a person who is newly diagnosed with hepatocellular carcinoma, surgical consultation, I think, is reasonable, and a reasonable surgeon would indeed conclude, based on review of this case, that this patient has unresectable disease due to tumor size and location. This would not be a controversial or by any means unusual decision. Therefore, the burden of addressing this person's comorbidities and in turn planning care in terms of treatment would not be on the surgical end of things, but more on the medical end with the multidisciplinary team's decision to initiate what would almost certainly be here systemic therapy. We know from the laboratory findings and the imaging that we just went over that this person has Child-Pugh-A cirrhosis, so he has fairly good liver function. We also know that he has what we call the Barcelona Clinic liver cancer, or BCLC stage C disease. Stage C is a disease that characterizes persons who have typically a fairly large tumor burden, as does this person, and also have either extrahepatic disease, as he does in the lungs, or macrovascular invasion, which we are not told he has. But unequivocally in this case, this patient has BCLC stage C disease. And the preponderance of the evidence, as do the BCLC guidelines, indicate that such a patient would be best served by initiating systemic therapy. We also are told that the ECOG performance status, which our audience would be very well familiar with, is 1. That means that while the person is not 100% independent in all activities of daily living, certainly has a high level of functionality that would allow him to be able to tolerate systemic therapy reasonably well. So after this workup is done and the multidisciplinary team meets and decides on a plan of care, the patient has lenvatinib at the dose of 400 milligrams PO every 12 hours initiated. He starts treatment and experiences diarrhea within 2 weeks, but this resolves without any specific interventions. Not an uncommon finding in patients who initiate TKIs in general and lenvatinib in this particular case. We are also told very encouragingly that he achieves a partial response, something that we would love to see in patients who initiate tyrosine kinase inhibitor therapy and is achieved in this person. By 2020, we are now 2 years later, another spectacular outcome in someone who's on TKIs for metastatic disease. We have imaging which shows a new lung lesion. At the time, second-line therapy is contemplated, and indeed, the multidisciplinary team recommends initiation of cabozantinib at the dose of 60 milligrams PO once a day, and this treatment is indeed initiated.